Okay, almost there.
F5.
I want to get the presentation view. There seems to be a slideshow here.
Oh, ignore my username.
Oh. There we go. Isn't there a presentation view?
Down to the bottom right, there's a little icon.
Tiny icon.
Yeah, but I don't think it gives me any. It doesn't matter. It's nice when you can see your
want
list
to-
of things. Yeah.
Or you can go back.
That's all right. Okay, so So I was going to tell you about platforms. Well, I've gone through most of it anyway. So in terms of our research group, there's a few platforms I'll tell you about. I said a few words already about the RX platform. I won't say any more about it. I'll say a few words about the Moxie platform, which is actually a platform in primary care for drug management. And then I'll say a few more words about the PopHR platform that I've been working on, and I'll finish by telling you a bit about the clinical data warehouse, which is probably of greatest interest to you. So I'll try and leave some time for that. So in terms of Moxie, this is to address this issue of, when a primary care physician gives a medication to a patient, they got to balance the benefits and the harms, right? And so one big challenge in older adults is that they tend to fall and be injured by their falls. And that's actually a non-trivial issue, as this slide shows. In Quebec, there's huge costs. One of the reasons for those falls is that a lot of older adults are on a lot of drugs that have what are called psychotropic effects. So they affect your level of cognition, your level of awareness, and may affect your stability. And we know that decisions that are made about the mix of these different antipsychotropic drugs that are given, psychotropic drugs that are given to patients in primary care, a lot of decisions are made at the time of prescribing, which could be modified to result in a safer profile of medications. And then, this is not like an insight of ours. People have known for a long time that you can do these prescribing alerts to let clinicians know that that medication might interact with other medications and cause a risk. But up to 90% of those alerts, even more in some studies, are just ignored, even critical alerts by physicians. And one of the reasons is those alerts tend to be very generic. They'll say things like, an opioid can cause sedation. Well, I think clinicians know that already. They're prescribing it for pain, and they're in their head kind of weighing that off. And moreover, that's kind of a general message. The implications for that specific patient aren't so clear. So, however, in the kind of era of personalized medicine, we're not really talking genomics. We're just talking about taking a lot of individual level data now. We can do a pretty good job of giving more targeted advice to clinicians about the likely harms of adding this drug or changing this drug in the overall profile. And so here's some examples. Traditionally, you might see an alert like this, but if we were thinking about a specific patient, we'd come up with a very targeted message. And our hypothesis is that doing this kind of messaging will be more useful for physicians. So what we did is we went and got a whole whack of data on over 400,000 older adults from the RAMQ. And we essentially built a cohort up from these people. We went back 2 years, and we tried to measure all those things you can see on the left of the slide from medical claims and drug data, and there are more or less validated ways of going about those things. And we create then essentially some fixed measures of those people as they come into this third year. And then what we do over that third year is we very carefully look at the change in all of these different types of medications that can affect their sort of cognitive status, if you will. And we're modeling these at the actual dose per day. And in drugs that are in the similar classes, we come up with comparable dose units. And then we can put that into essentially a regression model. And what we come up with are kind of risk factors for falling. And what we find is that the risk factors for a fall-related injury for older adults, many of them are non-modifiable. So they've had a previous fall, they've got cognition issues, and so on. And we can't do anything about that. But a lot of the risk comes from the drugs they're on. And these, we can give very targeted guidance back to physicians about how they might want to modify those drugs to attenuate the risk, or if they're planning to add a new drug or increase a drug dose, to show them what that risk will be. So what we did is we actually already had in place with about 100 primary care docs this system called Moxie, which is essentially a EMR, but more like a light drug management system, which pulls the data for the medications they're on from the RAMQ, gives you a summary of them here. And what we created working with different physician groups and doing a lot of prototyping around the feedback was essentially this little decision support box that would pop up when you had a patient who's on one of the implicated medications that are shown in red in the drug list up here. And then what we essentially show is for this patient, this is fictional data here, we can show their fixed effects on the left, which we can't modify. This is a 78-year-old woman who's on a number of psychotropic drugs, but we can show the effect coming from the drug. So this is the lowest risk that could possibly be attained, and this is this increase in their current risk that's attributable to medications on top of that baseline risk. And as you can see, we're giving them both a, in this case, we're showing that they've made a drug change now, and it's a slightly different risk, but they're on a much higher drug risk now, this person, but they've modified something in their drug therapy that's increased their risk. And so you can show them that you've actually increased this risk of 0.09 is that's a 9% probability of falling in the next year and having an injury. And they've now increased it to 11%, which is a 40% risk increase by changing the dose. And so as they change their drug dose in the prescriber, we're actually giving them very targeted feedback on what that means for a very clear outcome, which is a 1-year probability of a fall-related injury in that person. And so then we did a cluster randomized trial with physicians on this topic, and we did see actually a significant decrease in risk of injury when we actually randomized physicians to see this decision support versus just having the usual prescriber. And what you're showing over here is a bit of an effect modification, which the higher the risk is going in at baseline, the more likely this intervention is to be effective, which means that physicians are paying more attention to it to patients that are at higher risk when they first see them. So that's an example of one particular application we did, and this is something I think that's a challenge, is where do you go from here? So we built this interesting informatics tool. We've shown through a fairly well-developed trial that has an impact on an outcome that's important. How do you now kind of get that innovation out into the world? And this is an area that is challenging, and we've tried working with a number of commercial vendors and different strategies, and I'd be happy to talk about this more, but this is an area that is still quite challenging for us, is to think about beyond knowledge translation, how do you get the technology out there so it's actually having an effect? Okay, so that's Moxie. I'll say a few words now about the PopHR platform, which is the piece that I work on a lot. So this is a slightly different space now. We're kind of moving out of primary care and thinking about population health. This is just a quick summary of one way of thinking about how you measure disease in populations. I don't know how many people have seen these kind of metrics, DALYs. Anyone know? Okay, it's a summary measure of thinking about if you wanted to think about the impact of a disease, like cancer, some type of cancer, for example. You could just measure the number of people it kills. That'd be one measure of how important it is. Or you could look at the years of life lost, which would be to say that people live to an expected age and they're generally dying from this condition 10 years earlier. So you don't just count the bodies, if you will, you count the years of life lost. But you can also factor in time lived with disability. And so here, for example, if you think about your utility of life is going from 1 in perfect health to 0 and you're dead, you can also color, in a sense, how healthy you are between 0 and 1. And so what this is trying to show here is if you lived in perfect health until your expected life expectancy and then just dropped dead immediately, you would almost have, that would be as best you could hope for. You could lose years by dying early, or you could use quality of life by having illness, right? And so this is one metric that tries to summarize all that in one number. And why? So you can compare across conditions. So at a population scale, you can say, wow, and this is for an exercise from the Global Burden Disease Study, it's called for Canada, and they've done this for all the countries in the world. This is 2010 data. They do have some updates, but essentially they say that, wow, 87% of all premature death and disability in Canada is attributable to non-communicable diseases. 8% injuries, 5%. And this is not surprising on a global scale. And you can further refine this down to specific diseases in here, but the idea is to give this kind of overall picture of what's going on. And the reason I'm telling you this is because, as you can see, a lot of this is what we call non-communicable diseases. But from a population health perspective, we have really poor data on who has what chronic disease or non-communicable disease and what's causing it. And so what we're trying to do is put in place essentially an environment in public health or population health where people who are responsible for healthcare systems and population health management have the information on populations around chronic disease so they know what people have down to fairly high geographic resolutions in terms of incidence of these chronic diseases and prevalence, and they have evidence about what can be done about it. And they have some capacity to make better decisions about interventions. And so the challenge that we have in population health, which is perhaps not too dissimilar from areas in clinical medicine, is we have no shortage of data. We have tons of data. The challenge is how do we make sense of that data and how do we get information out of it that we can actually make decisions about. We also have the challenge that we know a lot. So this is from a somewhat infamous conceptual graph called from the Foresight group around obesity. And so what they're trying to show here is if you want to think about a chronic condition like obesity, which is a major driver of all chronic diseases, what causes that? And so this was an attempt of a large group to get together and do some conceptual modeling of all the factors that influence obesity. And so the reason I'm showing you this is because the challenge we have right now is that we have a ton of data. We have a hard time measuring that and getting information out of it that's actionable. But we also have a ton of evidence about what we could do about modifying that activity. And so what we're trying to do in an informatics context is bring together meaningful information from the massive data we have with evidence about how to act on it. And that's really what this project's about. And it's something that's called a population health record. And so that's not a term that we created. It's analogous to electronic medical record, which if you think about what an electronic medical record does, it's trying to bring for a single patient all the information together that's relevant for a clinician to make a decision about what to do next. So radiology data, lab data, so on, and compute indices from those and make it available for decision support. And so what we're saying is if we can define a population, like the region of Montreal, for example, where we have a group that's responsible for their health, can we take all the available data, calculate all these metrics about what's going on in terms of incidence and prevalence of chronic disease and possibly interventions, and have evidence about what are the effective interventions at a population scale or clinical health system scale to try and change things. And so this is a system that we've created. We originally got funding from Canadian Foundation for Innovation around 5 years ago. And that did the initial kind of build of this system. And now we have funding from the Public Health Agency of Canada, and we're working very closely with the Quebec government to implement this in Quebec. And so what we do is we start with a defined cohort, and it could be the entire population or a random sample of population. And we have individual level administrative data. We've designed our system to also accept clinical data from the Dossier Santé Québec, but that's not legally possible right now, so we don't have access to that. And then we define, in terms of formal ontology, which is a way of encoding knowledge in a computer system, how you go from the raw data to all of these indicators of all these chronic conditions, and moreover, how those indicators relate to one another. So what's the causal relationship between different factors, risk factors, and outcomes? And that's all formally encoded in a computable way. And then we measure exposures the best we can on individuals, because obviously it's very hard to get detailed smoking histories and so on in individuals. But there's an awful lot of data about the built environment and survey data that we can drive down to a fairly high geographic resolution. And then we make these indicators available. We're focusing primarily on public population health right now, but you could imagine making this information available in multiple different contexts through different kind of platforms. And the two innovations are, one, we really can come from raw data here, and we can compute and update automatically these indicators. And then the second is that we have this formal knowledge that actually allows us to link together all this information and, in fact, reason over that information, ask logical queries of it that we can then respond to. And so if you think about it, a lot of systems right now have all these indicators of health that are like a laundry list. And what we're doing is we're trying to actually bring in knowledge. The first knowledge that we're bringing in, which we already have in our system now, is this causal knowledge that links these concepts together. That's called type 1 knowledge in this theory of evidence-based public health. And then now we're in the process of bringing in evidence. And so we're actually working with people who have spent a lot of time trying to go through PubMed, for example, pull out full-text articles, and be able to parse systematic reviews and assess this is an intervention for what condition, what's the evidence and the grade of that evidence, and be able to link that with our information. So just a few kind of quick screenshots. Here's an example how if you go into this application, you ask about type 2 diabetes. We actually come back with a concept of type 2 diabetes. We list the indicators or measures we have under here. There's a drop-down list that gives you all of them. And then we show on the left side what concepts do we know about that are causal factors. And on the right side, we say what concepts do we know about that are downstream effects of that condition. And then these arcs and the concepts themselves create a graph that we encode based on consensus knowledge in literature. And we do that manually. And then what we can do for all of the data we have is we can start to look actually now, does the data support these relationships? And so we're doing this at a very high geographic level, and right now we're just doing simple bivariate correlation, but we're looking at more sophisticated statistical models on top of that. But so you can see here, we're showing a strong negative correlation between income and the prevalence of diabetes in all of the regions in our data. We're showing relatively strong positive correlations between some of these downstream effects. And so this allows people who are looking at a defined population to immediately see, what's driving what at some level. We can also, of course, show maps and provide these kind of, distributions by geographic regions as well about different indicators. Like this is standardized rates of diabetes. And so, as I mentioned, we're right now, we have been working now for about almost 2.5 years with the Public Health Institute here in Quebec to implement this computer system at their environment in Quebec City and to connect the data for the entire population of Quebec, so claims data for all 8 million plus people. And then we'll be rolling out this application to different regions of Quebec. And ultimately, we'd like to get to is doing cluster randomized trials where we can actually see how does this kind of information change decision-making about health planning and healthcare delivery. And more now, we're starting to work with INES to actually take this kind of an application and look at it not from a population health perspective, but more a healthcare delivery perspective. And you can imagine analogous sorts of indicators and metrics we could calculate from claims data and clinical data to understand how different clinical care is being delivered across the province. So that's one piece, and I'll quickly tell you about a second piece. So when we did that project, I don't know how many people were surprised by the fact that 87% of premature death and disability is due to chronic disease. Was that probably a number most people have? It's big, everybody knows, but that's big. And then we started thinking about, well, what drives that? Like, what are the things that are really driving that? And if you look at what's really driving chronic disease, and this is based on the Colbert disease study again, the number one modifiable risk factor is what you eat. And smoking is number two, not surprisingly perhaps. But underneath that, you can see we have things like high body mass index and a number of things that are actually related to what you eat, probably. But we know very little about what you eat. In fact, the only way we know what you eat is when we ask people by a survey once every few years, and people are really bad. In fact, some of them actively lie about what they eat, but many just forget. And so we do a really bad job measuring that. And so it seemed to us this is kind of ridiculous. If this is such an important risk factor, why can't we do a better job of measuring it? So we started working with colleagues in marketing at the faculty of management at McGill to understand what kind of data is out there. And it turns out there's a ton of data about not necessarily what you eat, but what you buy. So everywhere you buy something gets scanned, and then those scanner data that happen at the actual cash register, they get aggregated either by resellers like Nielsen Corporation that pulls those from all different retailers and then tries to resell the information for marketing purposes back to Pepsi or back to a grocery store. But then there are also loyalty card programs. So within a single retailer, they pull all of that transactional data together and they link it to your loyalty card. So it's data over time now. And then because those data are maintained at a very granular level, you can actually link each item that's purchased in a basket, essentially, to the nutritional contents for that item. So I think you see where I'm going here. You can now start to roll up at population scales what people are actually eating in some measure of how healthy or unhealthy it is. And so we've actually been doing this now in two different ways. One way is with that data from Nielsen I mentioned, which is has a structure that looks a little bit like this, where we acquired weekly data for the whole province of Quebec over 6 years. And it's a sample of all grocery stores, pharmacies, dépanneurs, and big box stores, essentially. And for each store, we get a weekly record of, at each UPC code, how many they sold, at what price, and a bunch of other information about how it was promoted in the store and so on. No individual linkage, it's just a store level now. But from giving a population perspective, it's fairly useful data. And we can get the full sampling frame from these business registry records, which tell us where all the grocery stores are, for example. And so we can locate our sample within that overall sampling frame. And we've done a number of things with that. I mean, I've had one doctoral student looking a lot at fruits and vegetable purchasing. So she created these standard baskets of fruits and vegetables so that she could sort of see, which fruits and vegetables are bought consistently across all stores throughout Quebec in her samples. It's just grocery stores now here. And now you can start to look at what's the variation in these standard baskets in terms of frequency of purchasing and price by different geographic regions and over time. So one thing she looked at was just the variation in accessibility and affordability of fruits and vegetables by urban and rural regions. And as you might expect, she finds that there is an increase actually in terms of when, and the question here actually she was trying to address specifically was, you may have heard the term food desert. So there's this sense that if you live in a kind of a more deprived area, you're not going to have access to as many supermarkets. And supermarkets are seen as the stores that have healthy food, whereas other kinds of stores like corner stores, not so much. And so the thinking is if you could just put more supermarkets into more sort of deprived areas, you'd have more healthy food and people would eat healthier things. So what she's showing here is that in fact that incremental effect of having an additional supermarket actually seems to in fact have different effects in rural. So in rural settings for fruits, if you have an additional supermarket, you do tend to see a lower price. Whereas she found exactly the opposite in certainly in urban settings, not quite significant here, but certainly for vegetables it was. Which is interesting because it suggests that there's some different dynamic happening. When you get additional numbers of supermarkets in urban areas, it's probably because they're trying to actually have a niche where they're a higher end one, it drives the price up and has different dynamics. So anyway, just to say is that by using the sales data in the grocery stores, you can get a much more nuanced picture about the influence of accessibility on what people are purchasing. And so this was kind of interesting. We've also looked at you may have missed it, but POP, which is Public Health's new smoking, is sugar, and so there really is no nutritional value in carbonated soft drinks. So looking at them is kind of a useful metric of healthy eating. And this was a different PhD student that looked at the question of, you may have heard this debate about taxation of sugary soft drinks, and so some cities have gone ahead and taxed sugary soft drinks. Canada is debating where to go on that one. What we wanted to see is, well, we know that there's a lot of discounting. So you can lower the price, or you can increase the price of something by adding a tax. But when you go into a grocery store, one of the most commonly discounted things is pop. I don't know if you've noticed that, but sometimes it'll drop by, in this example, up to 15% discounting. That's on this x-axis right here is the discount level we're seeing in pharmacies and supermarkets. And what we want to know is, does that differential, because if you think about it, if you have a tax in place, if they just discount it, there's no effect of the tax, because they've just actually changed the effective price by introducing discounting. And that discounting does not always have to be uniform across the entire population. Discounting can be targeted at different areas. We already know that elasticity in terms of when the price goes up, it has more an effect on people who are of lower income. And the same happens when the price goes down. And so what we wanted to see here was, first of all, do we see evidence of differential discounting by deprivation or by median income? So are stores aggressively discounting lower quality products in poorer areas? And we didn't see that, thankfully. But what we did see was differential uptake, or what we say in epidemiology is effect modification. So what we're showing here are for the regions around the supermarkets and pharmacies in the region of Montreal, we're showing the tertiles, or 3 levels of education here, high school education in the areas around the stores. And we're showing, so this is the lowest level of education to the highest level of education in supermarkets and pharmacies. And what we're seeing is as the discount rate goes up, we have a nonlinear relationship between the amount purchased in the lower income areas compared to the higher, or lower education compared to higher education areas, which suggests that when the same amount of discounting happens around a product like pop, we're going to see more uptake in lower education areas than higher education areas, which increases inequalities in diet, and we will increase inequalities in chronic disease down the road, is our assumption. And so this is important policy information, if you will, for how taxation is put into place and whether you need to put some limits in terms of discounting in relation to taxation. Yeah, and so I won't go into great detail, but we've also shown that we can take these sampled stores, which you see as stars, and we can predict out for all the unsampled stores and get very accurate predictions of what's being sold in those unsampled stores. And what that allows us to do is come up with relatively smooth layers of purchasing of, in this case, carbonated beverages, sugar-sweetened carbonated beverages, in areas even that don't have stores. So we can actually smooth out that purchasing fairly accurately across all regions, and then come up with metrics that, don't forget, these are these metrics are being driven by transactional data. So we can actually update these metrics almost in real time if the data are in real time, which gives public population health people very clear pictures on if they're putting in place interventions to try and reduce exposure to some or purchasing of some of these things, is it being effective or not? And I won't say a lot, but that was all at store level data. And now we also have a partnership with a large grocery retailer in Quebec who has given us access to all of their transactional data for all their stores linked to loyalty card data. And so that allows us now to think about looking at temporal patterns of purchasing within households. We don't have any data on the households themselves, we just have that linkage over time. But one thing that we've started to do, for example, is just look at the proportion by price of your food items that are spent on fruit and vegetables, for example, as a rough metric of how much of fruits and vegetables you're buying. And we can see these interesting, this is one example of one store we looked at where we have I think we have 2 years of data, 2.5 million baskets approximately. And we can look at the variation over time in purchasing of fruits and vegetables by proportion of price and then overall. And so we're starting to tease out now these different sort of cohorts, if you will, that we can start to see how they're responding to different types of incentives that might incentivize healthier or unhealthier foods and see what kind of response they're having. And we think this is really interesting for developing technologies down the road for people that are interested in eating more healthily, and maybe even connecting some of the information around healthy eating with health outcomes. As you can imagine, there's a space there where if you have a disease, you may want to modify your diet. If you're trying to prevent having a disease, you may want to modify your diet. And if we're actually monitoring very accurately what you're purchasing, we can give fairly targeted guidance to people. And so that's sort of a space we're exploring down the road. Okay, so I'll just finish then with a few words about the clinical data warehouse, and then that will hopefully leave time for questions on that topic, or if you have other ones on that as well. So our research group has actually done a number of studies using data from MUHC, as a few that are shown up here. I mean, one of the major limitations for these studies is getting the data. And I'm sure many of you had this experience. For all of these studies, we had to go and meet with, people in the laboratory, people in pharmacy, and figure out how to pull the data, figure out how to stitch the data together, figure out how to scrub the names off the data, all that kind of stuff. And so we decided, and in fact, this is something that had been tried even before at MUHC, but we had, as part of the CFI I mentioned before that helped to build some other infrastructure I showed you, we actually also received some money to build a clinical data warehouse here at the MUHC. It just so happened at the same time that the MUHC itself had allocated resources to do a similar sort of thing for its operational needs, and so we pooled our resources and decided to build a clinical data warehouse to pull together data from multiple clinical and administrative systems here at the MUHC that are used in a routine operational way and make them available for what I call secondary use. So that could be, financial analysis, quality and safety, or research. And this is not a novel idea. It's been, I think, done around the world for a number of years now. Starting at around the 2000s is when some of the first academic health centers were doing it. Mass General published some of their results in Boston. They put in place a warehouse, and it generated a lot more grant activity and research around analyzing these data. And it's also been shown that having a data warehouse really facilitates finding patients for studies. So who qualifies, who's going to fit my criteria, you get sort of more effective protocol design, and you can recruit patients faster. So that's what we've done. This is just kind of an overall data view, if you will, but at the center of the whole data model is a patient and an episode of care. So everything's structured first around people and then around their episodes of interaction with the MUHC. So no data element is hanging out there without being linked to some kind of episode which is linked to a patient. Then what we've done is pull data directly from different domains or source systems. We did go through a process with each of the source systems of trying to identify what were the relevant variables best we could for research purposes. And then there was a quality control step working with people who operated that source system to kind of feed back to them the data that we were extracting to make sure it was consistent with what they understood the data to say. And so we went through a long process, source by source, of pulling the data, trying to map it into a new format, making sure in the new format it was consistent with the old format, and then stitch all those separate domains together in terms of a larger warehouse. We've also spent a long time thinking about the mechanics of how people would ask for data and get access to data, and how that fits with the governance and ethics and legal requirements around the MUHC. And so what we've essentially done is we've created this one warehouse that pulls data from a bunch of different systems, and that still has nominal identifiable patient data. And then we have a copy of that where there's no patient identifiers, it's an anonymized warehouse. And researchers can request access to data from either, but but to get access to the nominal data, of course, you need either patient consent or a waiver by the Director of Professional Services. For the anonymized data, you need REB approval, but not the other two necessarily. And for the anonymized data access, we're trying to have a very accelerated process because it's very low risk to get access to those data. We're also creating a series of tools to facilitate exploring that data warehouse, understanding what data elements are there, both in terms of like the fields, but also the actual data values and distributions of data. Yeah, and that's it for the warehouse. So in fact, I'll happy to take lots of questions. The overall timeline here is that we're doing what I would call a soft launch in November, where we're going to start to roll out some of these tools that allow people to explore what's in the data warehouse. And then starting in February 2019 is our target to allow researchers to request extracts from the data warehouse for analysis. And that's kind of the overview, I guess, I had planned. Just to say that we have, as I mentioned, a fairly large team that's contributed to the research I mentioned, and lots of funding, some publications if folks want, and those are our websites that if you want to go find out more, or you can email me as well, but there's some information online. And I'd be delighted to take questions.
Thank you very much for a really nice talk. I'm sure there are some questions. Okay, we'll start at the front. Avi.
So for anonymizing, what exactly are you removing?
Sure. So we went through every field and every source to see whether it would allow us to directly identify an individual. And so that means there would be a name, a birth date, an address, anything. And there's actually a set of things that could be there that are pretty well defined that we want to make sure we're not there. If there's any doubt, we did not pull it across the anonymized warehouse. So all that information is pulled into the main warehouse. It's just not carried across. So for example, radiology reports are not currently pulled across because we cannot guarantee there's not a name in there. There are strategies to de-identify or anonymize reports like that, but that's in our second phase. So once we have this system up and running, we're going to put in place a series of studies to try to see how well we can scrub those kinds of nominal data from those kinds of things to hopefully make them available in the anonymized warehouse.
Can I ask maybe a follow-up question? Yep. It sounds like you've got two separate data warehouses.
One's a mirror of the other one, basically, but dropping a number of fields. So
I'm wondering why you didn't build like an abstraction for the anonymized version that would just get the data from one source, but filter it before it goes out.
I mean, you're right. Logically, the same thing. I think it made it easier for the REB to get their head around.
Okay.
That this is a separate entity, and one of the conditions of calling something anonymized is you can't go back. Mm-hmm. So we cannot. There is no sort of key, if you will, to pull somebody to an anonymized warehouse and unlock their identity.
Okay. Yeah, that makes sense.
Yeah.
Yeah.
So just it's a side note, it's not a question. But for example, if you have a PDF that you black out and you upload to Google Drive, it's visible. Like blacking out does not work.
It depends how you do it. Yeah, you'd have to actually I've done that. Yeah, if you take it and you actually print it as a new PDF, it's an image.
Yes.
And then but if you just if it's just a markup on the PDF, you're right. It's
software. Depends on the software used, no?
It does. It does.
Shireen?
Just have an ethical question. Can insurance companies use this, although everything anonymized, but demographically?
The data warehouse?
Yes. So can insurance companies use your data warehouse in future to not insure certain demographic areas, say depending on non-healthy eating?
Well, no. Well, I mean, I shouldn't say no. So for the main data warehouse, it's considered medical record. So to the extent that they can go into the medical record room and look at your medical file, they can look at the data warehouse, presumably. It's just, it's an easier way to get access to that information that's stored in your medical record. So there's the same legal protection on that warehouse as there is on a paper dossier.
But were you asking maybe more about the population? Because
It's
if you-
population-based one. So based on a population, say that it's not individual, but just looking at the results, you can go to a certain area and say we don't want to insure you on this because of...
Funny you should say that, because Blue Cross, actually, from the U.S. called us. And they were very excited about the work we were doing with grocery purchasing data, because they were doing exactly that. Yeah, and we didn't, I mean, there are ways you could do that. And we ended up working with them because we were not completely down with that, but they're already doing that in the United States right now. I mean, not at the individual level, but exactly as you say, just the way that your car insurance depends on your postal code.
Yep.
I wouldn't be surprised if they're doing the same thing with your health insurance.
But can you just tell us, Canadian in general say that do they eat, like, have you tried to pattern the eating? Or do you have any eating patterns for, say, Montrealian? Do they eat healthy or not?
Oh, we got lots of that, yeah. I mean, well, let's be careful. We can see what's being purchased.
Right.
So we only have grocery purchasing or purchasing some of these other, depending on the data source. We don't see anything about restaurants. So there are some important gaps there. But nonetheless, we can make comparisons between regions in Quebec, and if we had the same data across Canada, we could do a similar thing Canada-wide for sure.
So, William?
Very super interesting talk. I just had a couple of questions about the data warehouse
Yep.
element. So you said it's centered around an episode of care. We're also interested in kind of, because we're not very good at keeping track of outcomes.
Yep.
As people are in controlled clinical trials. I suppose it's going to be one of the objectives of your work. So when does the episode of care kind of end, or maybe you can put it another way? Is the data warehouse being updated constantly? So we have a patient comes here and they get a sequence of events that happens, and then they're followed for years and years and years. So how does that information get back into the data warehouse?
So
Or does it? The outcomes.
So the flow into the warehouse is, nothing has changed in the warehouse. The warehouse is essentially just like, whatever comes out of those production systems is what you see.
Those systems all the time?
All the time. So the central warehouse is updated daily, and the anonymized one is currently weekly off that one. So in your example, as long as they keep coming back for care, you'll get those follow-ups. Right. We have thought about and have had some discussions with people both at the MUC and the RI about making a request to the government to be able to get claims data for all those people. Wouldn't that be nice? And then you'd have actual outcomes regardless of where it happened in Quebec. But that, as you can imagine, has some political overlays on it. So we'd like to get there, but that'll take time. So right now, essentially what you get would be any interaction they have with the MUHC that touches one of those systems would show up again in the warehouse. So we're capturing inpatient, including short surgery, ED, and outpatient encounters.
And who gets to use this warehouse?
Anybody for a research purpose, anybody who has a PI privileges with the RI can request access. And on the clinical care side, you can also request access to the nominal one or the anonymous one for clinical improvement. Yeah.
Just a follow-up question on the data warehouse. It's within the MUHC. Do you have any plans to go beyond the MUHC and link multiple institutions? Because patients aren't just seen at the MUHC.
Yeah, absolutely. So one way of thinking about that is getting those claims data in. Also, there is an initiative between the different academic health centers in Quebec to try and look at interoperability of data. And so we're planning our first meeting with the SHUN, sorry. They have a similar data warehouse initiative moving ahead. It's a little behind us, but the idea will be, and this is a strategy that's working around the world already, is that we can both map our warehouses to the same common data model. And there's been one that's specified, and it's called OMOP, Clinical Data Model. It's been pretty widely adopted. And there's a number of software tools that then allow you to do queries across different warehouses. So within the next, I don't know, I hate to say dates, but my lifetime. Hopefully, next few years, we'll hopefully be able to do queries across MUHC and SHUN warehouses, and St. Justine as well. It's working on it.
Regarding the grocery purchasing data,
Yep.
I noticed that the total percent of funds purchased on fruit and vegetables per transaction seemed to peak in January. there a suggestion that is seasonal dieting?
Oh, there's huge seasonal patterns in all of these things, but I have a PhD student, one of her papers was just on seasonal pattern variation in fruit and vegetable purchasing. And it's quite pronounced. Well, I mean, what she showed is not only the purchasing changes, the price changes considerably. Because people often think about, I mean, one of the biggest problems for buying fruits and vegetables, people say, is price, especially out of season. And so that sort of inaccessibility, if you will, from a price perspective, is actually very significantly higher in some seasons than others. And so she wanted to see, what, she didn't come down with actual numbers, but it probably does push a significant number of people into the kind of unaffordable range, basically, with those seasonal variations in price, which in turn drives, as we know from elasticity, changes in purchasing.
That made me think as well about my own parents who live in the countryside, and they grow their own vegetables in the summer.
Yeah.
So your rural city divide could be...
Absolutely. And you have fruiteries in cities, which are not evenly spaced. There are some areas that have more. So there's definitely some holes in those data. But looking at, that's why we tried to focus on price, because, price should, even though we're not getting everything, presumably the price will kind of calibrate. If there's a lot of fruiteries, you'll have to see a discount, but we're not sure. The other way you can do is by looking at retailers and trying to follow people who do, in marketing, they have a concept called frequent shoppers. So once we have that kind of the loyalty card link, we can look at people who purchase at least twice a week from the same place and purchase a basket that's at least a certain amount of value. And there are certain analyses that have been done in marketing. We can say, you know what, for these people, we can be 90-something% sure they're buying all their food at this location. And then there's a bias introduced by selecting those people out, but then you can sort of see, what's going on with their basket, basically. But yeah, this is a perfect example of interdisciplinary research. If we just grabbed that data and tried to analyze it without working with people in marketing, we would have made all sorts of stupid mistakes. We probably still are, but at least by working with them, we're benefiting from a lot of that expertise.
Very interesting. Any other questions from the floor? All right. In that case, we'll thank David very much again. Thank you. Good. Very nice. That's very different for us.
Yeah, I was going to say, not sure the medical physics, so...
I think it got people thinking.
Actually, you get a sense of the kind of thing you do.